Dear brothers and sisters, Assalamu alaikum wa rahmatullahi wa barakatuh, and welcome to a new episode of Health from Huda TV. Heart attack has been very commonly seen in the previous decades, and it has been forming a big problem, big issue for the healthcare and for the medication these days. With us today is Dr. Ahmed, consultant of interventional cardiology and the director of the cardiac catheter unit in the Arab Contractor Medical Center. Welcome, Dr. Ahmed.
Thank you.
Thank you very much for hosting us
You're
today.
Welcome. It's your place.
Hosting the program. Cardiac attack has been very commonly seen, as we said, and even more in the younger category of age. Usually it was seen in the older age. Now it's very common, more prevalent in the younger age. What is cardiac or heart attack?
Heart attacks, it means any acute cardiac events that affect the patient, whether it's coronary heart disease, whether it is heart failure or whatever. These acute events, it's a major cause nowadays for the cardiovascular death.
Yes.
And its prevalence changed from the elderly and become more in the young, mostly because of the industrialization and the new lifestyle,
yes,
which makes we are doing less activity, more sedentary life.
Exactly.
The way or the quality of food we are eating, the diet, which is high caloric, high fat diet, most of these things, and the first issue we are facing nowadays is the stress. The
Exactly.
Emotional stress, which we are facing worldwide, not only in Egypt, but it is a worldwide problem, and it is the main issue of provoking coronary heart disease, heart attacks, because you know that we have a sympathetic nervous system which is provoked in such cases, and it is the main provoking factor to start the coronary heart disease acute events.
Yes. I want you to take us through a journey, starting with somebody who has a heart attack, and I want you to show our audience here, our viewers, the basic information about how heart attacks happen and how do we deal with them. In the first, when he gets it at home, how he would predict it, how would you do the first aid, and what happened in the ambulance, and all the way to the final treatment of heart attack. So please take us to...
It's a big question.
Yes.
It needs to be sectioned. First of all, the heart attacks or the coronary heart disease, it's either atherosclerotic or non-atherosclerotic. Atherosclerotic means it is a fibroproliferative immune inflammatory disease which results in thickening of the lumen of the vessel, thickening the wall of the vessel on the expanse of the lumen, and this results in lumen narrowing. This lumen narrowing will increase and will decrease the blood supply to the heart muscle, and this is what we call angina. The patient will feel angina whenever he do any effort because of the unsatisfactory amount of blood. The other issue is the non-atherosclerotic, which mostly it goes from thromboembolic, which means thrombus in the coronary artery,
yes,
or spasm, it means constriction in a very short time, and it is relieved. It's not, if it occurs for a long time, this means the patient will go on for MI, which is myocardial infarction.
Yes.
And something like dissection, which is the wall of the artery will be separated, it will be not in one unit.
Yes.
No, the artery will be separated to intima and medial, and this allow for blood clots and mural thrombus to occur inside the wall itself, and this will result in compromising the lumen of the vessel.
Yeah, that sounds very scary to our viewers, so we need to tell them, first of all, when should they predict the heart attack, and if they have the pain of it, and or to exclude it, because some people would predict that if they have chest pain, they have pain going to the left shoulder, then it's most probably heart attack. So you'll be telling us how things would be differentiated between heart attack and other causes of this pain. We will take a tour in your hospital, as you promised, to show us all the sections and how do we deal with a patient with heart attack. So
sure,
please go ahead and take us through. So now let's talk about somebody who has this pain in the chest. Of course, most of the people, when they, as we said, when they get this pain in the chest, start to think that they have the cardiac attack. What are the characters that would say that this really is a cardiac attack, or this is other cause of pain of the chest?
The patient will be lucky if he got the typical way of the expression of the acute coronary events.
Mm-hmm.
Maybe most of the time it doesn't come this way. The typical way of angina or coronary pain is compressing, heaviness, squeezing, tearing in the retrosternal area.
In the
like
middle
this.
of the chest?
Yes, in
Yes.
the middle of the chest.
Yes.
And mostly it radiates. This radiation may go to the left shoulder, left arm, fingers, to the neck, to the cheeks and teeth.
Yes.
Okay?
Up to the teeth.
Up to the
Because
teeth.
somebody would tell you I have a pain in the shoulder and going to my arm, I believe I do have a cardiac attack. Well, is that common to be?
Usually it is a radiation. The pain got to have the source.
Yes.
The source is at the chest.
Yes.
If we have only the radiation, mostly it is not a cardiac pain.
Yes.
But I should appreciate this pain.
Yes.
Don't neglect it.
Exactly,
Any
it's
pain
true, yeah.
in elderly patients, especially if they are diabetic or at risk, this pain should be appreciated and should be fully investigated. Most of this chest pain didn't come in a typical way, as I said to you.
Yes.
Maybe it come in a way like shortness of breath, fatigue, easy fatigability, unexplained sweating. It means sweating in a cold weather.
Uh-huh. Yes.
Usually, you got to be afraid from such a symptom. I faced before with a patient, the only symptom which I got is unexplained sweating. The patient came to me, I have sweating since about half an hour and I don't know why. Do you have any pain? No.
Uh-huh.
Do you have any shortness of breath? No.
So it's not essentially a pain. It's many symptoms that could happen with
Yes,
what
yes,
do
that's
you
what I
call
mean.
the atypical cardiac,
Atypical form
atypical
of
form of cardiac.
acute coronary pain.
Yes.
So any risky patient have any chest on or this area symptoms should be fully investigated.
Yes, you
in
said
a
the word
hospital.
risky, which is very
Yes.
important to listen to our viewers. Who's more risky or more reliable to have this cardiac attack?
The risk persons, mostly those who had dyslipidemia, and I know it's a medical term. Dyslipidemia, it means the high blood cholesterol,
Yes.
high triglycerides, high LDL, which means the low density lipoproteins.
Yes.
This is the first. The second is heavy smokers. And
course.
we have 5 million deaths per year worldwide from smoking.
5 million.
Yes.
Uh-huh.
And we have hypertension, which contributes for 50% of acute coronary events.
Uh-huh.
We have those with have sedentary life, the lacking of exercise, obese person, and we are saying obesity nowadays, we are calling it the metabolic syndrome. This will have central obesity and with high triglycerides, high decreased HDL, and insulin resistance. So, if we are having symptoms in such patients,
Yes.
this patient should be very. Their symptoms should be very appreciated,
Yes.
and they will.
You have to deal with
full
it.
investigations.
So
for
somebody getting this chest pain, a typical chest pain for the cardiac arrest or the cardiac attack, and of course until he can call the ambulance or get the medical help, there is some time, a gap of time. What should they do, or how would they manage until they get somebody to help them?
First, we got to know that the time factor is very important.
Exactly.
So this patient should, the first thing to do is to relax. If he on exercise, he should rest himself.
Yes.
Then he should take about 2 tablets to 3 tablets of aspirin.
Aspirin.
And then we have these drugs which dilate the coronary artery. It's called the nitroglycerin or nitrates.
How would they get it? They should have it at home if they don't have it at home.
Mostly
What would they do?
Mostly I advise the risky patients
Yes.
to always have this in their pockets.
In their pockets.
In their pockets.
Okay,
If they are outside or in their home.
until the ambulance comes or somebody
By
brings
the
a
first,
medical help.
by the first nitroglycerin tablets, he should call for an ambulance, not to wait more.
Yes.
And until the ambulance come, he can take another 2 tablets with a gap of 10 minutes if this pain persists. If the pain persists, he can take another tablet, and after 10 minutes, he can take a third tablet, 5 to 10 minutes.
Okay.
Okay.
The role of ambulance these days has changed from how it was previously, just a mode of transportation, of transporting the patient just to the hospital, to a real and effective way of treating, or at least maintaining the patient's or the person's life until he gets the proper medical management in the hospital. So I want you to take us into the ambulance here,
Of course.
and show us what would the ambulance do to a patient with a cardiac attack,
Okay.
please. So this is the ambulance, and this is, as you told me, one of the most recently renovated to be equipped to be suitable to transport a patient with a cardiac problem. So I want you to tell us more about what's in there, what are the equipments and the preparations in there, please.
Sure, I will be in
Please.
the ambulance itself. This. Now we are in the ambulance.
Yes, so this is the ICU ambulance, which
The-
is, you told me, it's quite different from the ordinary ambulance that we know.
This is one of the most advanced ambulance, and it is equipped mostly for the cardiac, to deal with any acute cardiac events. And it has the equipment which we have, right, you can see it right here, that can help the ambulance team to deal with such cases.
Okay, so when the patient comes in here first, when the ambulance team brings him to the ambulance, what are the steps they start to do all the way until he's in the ER?
First of all, we have the patient. We will have on the stretcher.
Yes.
The patient we will take the vital signs of the patients, mean the blood pressure and heart rate. We will connect the patient to an ECG,
Yes.
to an ECG, so we can find out if there is any changes in it that imply or denote coronary heart disease, acute coronary heart disease changes. Then, if we find any changes, especially if we found S-segment elevation in any two consequent leads, it means two adjacent leads in the ECG, so we got to call directly the hospital to prepare the cardiac cath unit team
For an emergency cath.
for emergency cath.
Yes.
Okay, then the patient, if we have decrease in blood pressure,
Yes.
we have here, you can see, two infusion pumps. These infusion pumps, where we can put drugs or medication that will support the circulation and the blood pressure. Second, we can see if we have any fatal arrhythmia. This is what's called DC shock.
Yes.
If the patient went for ventricular fibrillation or VTAC, sustained VTAC or something like this, and become hemodynamically unstable, we should start to do to give this DC shock
Yes.
until the patient is quite the heart rate become quiet again or stable again,
Yes.
or it means we call it sinus rhythm again.
Yes. So on the journey of the patient to the hospital or to the ER, the paramedics, and of course usually this car, as I know, would have also a doctor in it, not just
Sure.
Yes.
Sure.
A cardiologist.
Yes.
Yes.
Because this is not just an ambulance. This
Yes.
is, we can say it's small ICU, that we can deal with most of the emergencies here, right here. So this is real life and ICU management for any patient with acute coronary heart attack events.
Yes. Brothers and sisters, we have a short break, as usual, and we'll be, after this, we'll be coming back to go into the real management of the patient with a cardiac attack, so please stay tuned. Brothers and sisters, assalamu alaikum wa rahmatullahi wa barakatuh. And we're back. And now we're in the emergency entrance of the emergency room. And Dr. Muhammad, when the patient arrives to this place, what happens next?
Next, we'll take the patient directly to the intensive care unit, or
Yes.
to be more specifically, the critical care unit, or the CCU,
Yes.
where the patient will be fully investigated and properly managed in the ICU.
Okay, so please, would you take us
Okay,
there? Thank you. Assalamu alaikum.
Assalamu alaikum.
Assalamu alaikum.
File, please. Thank you.
Now we're in the CCU, or the cardiac care center, cardiac care unit, where the patient is supposed to be directly transferred from the emergency room to this place to be taken care of. You'll see that each patient has his own room, his own compartment, so to maintain his privacy and to be able to properly manage him, would you take us please to one of the rooms?
Sure.
Yes.
Now, after we have the patient transferred from the ER to the ICU or the CCU unit, as we said before, the patient will be connected to the monitor, as we see here. This monitor will give us the reading of his vital signs. Then we will take full lab investigations, some blood sample for full lab investigations, especially for renal function test. If the patient we are going to have cardiac catheterization for him. Then second, the patient will have all the medication, the emergency medication, like oxygen, like painkillers, like morphia, and we will give him beta blocker, aspirin, and clopidogrel. If the patient is not loaded either in the ambulance or in the ER, the patient will be loaded here for clopidogrel as preparation for the coronary angiography. Then my colleague, Dr. Abdurrahman, we will give us a brief idea about the role of every device here in the ICU unit.
We have some extra device which we might use if the patient needs. This is the intra-aortic balloon, which we might use if the patient develops septic shock, which is a very which is very dangerous for the patient. If we don't have this machine, we might lose the patient. This is DC shock. We might use it if the patient develops any fatal arrhythmia, and also should be available in every CCU unit, because at any time the patient develops fatal arrhythmia, we might lose the patient. And this is a mechanical ventilator which you might use if we need any respiratory support for the patient.
Okay, Dr. Abdurrahman, thank you. And now we will categorize the patients, whether this patient will have only medical treatment or will be transferred. We have some criteria which tell us which patient should go directly to the cath lab. Yes. Mainly, if we have S-segment elevation myocardial infarction, or new onset left-bundle branch block, or if the patient developed non-ST segment elevation myocardial infarction or unstable angina plus hemodynamic instability. It means we have decrease in blood pressure up to shock, or the patient developed cardiac shock, or the patient developed heart failure, or the patient developed fatal arrhythmia. Yes. This patient should be urgently and at once directed to the cardiac arrest unit, where he will receive his final yes. medication.
So I want you to take us to the cardiac catheter unit to show us the details of how the catheter is done and how the preparation of the patient takes place in there, and the whole procedure of the cath. Okay. So please, take us.
Let's see.
And now, brothers and sisters, we are inside the catheter lab, where the cardiologists do the cardiac catheter, the stenting, and the ballooning, as we all hear about it. And Dr. Muhammad, please, would you tell us, when you bring your patient here, put him on this table, this is your home now, and you tell us how would you start with the patient for a catheter?
First of all, we will have the patient lie flat like this, and the patient, we will sterilize him in whatever the area you will do the cath from. You either do it from right or left femoral, or right or left radial.
The femoral is at the
artery
hip.
of the leg.
Yes.
The artery of the leg.
Yes.
The radial is the peripheral artery of, or the distal artery of the
Here.
hand. Yes.
Yes, okay.
Yes. This is more sophisticated, but it is more ample to the patient, less hospital stay and less bleeding.
Okay.
This is favorable for many cases, especially case on anticoagulant or patient with high bleeding tendency.
Okay, so since we don't have a patient, you brought us the tools that you work with, and of course we should start with the catheter itself.
This is the catheter.
This is the catheter.
Now
yes.
the patient, after we give him the pre-medication, which mostly for antihistaminics and for if the patient got to be sedated, if the patient is anxious, then we will do the puncture of the artery, whatever the artery femoral or radial.
Yes.
Then the patient, we will give him a local anesthesia,
Yes.
either Xylocaine or whatever the available.
Yes.
Then we will puncture the artery by a needle. After this, we will have a short wire. With that, we will enter. We will put it, and then we will take out the needle.
Yes.
Then we will put a sheath, which is a rubber thing, just like the cath,
Yes.
but short one. Okay. We will put it instead of the wire, and we will remove the wire out. Now we have a sheath inside an artery. Sheath is something just like this inside the artery. This is the first step.
Yes.
The second step is to bring the catheter itself. Okay, we will have the wire, but a longer wire, which it's about 150 centimeter long, and we will put it inside the sheath, and on the wire we will have the catheter itself, and we will push both the wire first and then the catheter on it till we reach from the femoral artery to the aorta, to the descending aorta, to the arch of the aorta, and to the ascending aorta, where the coronary artery arises.
This is of course done under the help of the X-ray.
This is
X-ray which moves on the patient. Yes.
It is movable.
Yes.
And the table also will move it and reach just the thorax at the thorax of the patient. And we have many views that we can take.
Yes.
All around the patient, either cranial to caudal or right to left, which are called right anterior oblique or left anterior oblique.
Okay, I want you to show us this on the screen. You'll be standing on my side, and looking on the screen.
Okay.
This is, of course, the dye that you inject.
The dye, after we reach the coronary artery,
Yes.
I will take the wire out, and I will put, I connect the pressure system or the hemodynamic system
Yes.
together with bore, something like called manifold that got a bore that allow us to inject the dye. The dye is the way that show us the coronary.
Yes.
It is radio opaque, so it is under skin, can be seen perfectly.
Yes.
Okay. Now we have the diagnostic catheter reaching the ostium of the coronary artery, coronary arteries, which are the blood vessels that give blood supply to the heart. And it is on the surface of the heart and not deep as many of the people think. This, after we inject the contrast or the dye, now we can see the blood vessels of the heart. One of them is totally occluded, and it is the source of the heart attack, the title of our episode today. And now we will take the catheter. This is a diagnostic catheter. We will take it out, and we will proceed for the intervention procedure. Now we have changed the catheter with a guiding catheter that give us more support for the intervention procedure. The guiding catheter will reach also to the coronary ostium of the left system, and then we will push PTCA guide wire that will pass the site of the total occlusion or the blood vessel, which is totally closed. And we can see that the wire have passed the site of the total occlusion, and we fixed it distally. After this step, we have two options: either to have an aspiration device, which is a device which get the thrombus out of the artery, or we will do a balloon if it is not available. This device is not available. After that, you can see here that the balloon is inflated, and then we will have the balloon out, and we will do the final step, which is the stenting of the artery, and it is the main issue of the coronary angiography, which is to obtain and maintain an open artery.
Okay, so after you take out the patient from here, after doing the catheter and all the ballooning or the stenting, what are the steps that would take him to go back safely back home?
Now,
How long? Yes,
after we finish, the patient will be transferred again to the CCU. He will stay for about 24 to 48 hours, just for follow-up for any reperfusion insult or any reperfusion arrhythmias. Sometimes it is very fatal arrhythmia, so he gonna be monitored for this period, and for the cardiac enzymes to be stabilized, and for the general condition, if there is any hemodynamic instability, to be stabilized. After this, the patient can be transferred to the ward and then to his home. But first, we have the cardiac rehabilitation program. The patient got to be educated about the disease process and how to prevent this again, which is called the secondary prevention of coronary heart disease, and which type of food, the load or the exercise or the effort he should do, and at what time. And this is individualized. It's not for all patients. Some patient can go on after 3 weeks. Some patient, no, I will do a stress test first, and the patient if not applicable for sterness exercise, so I will wait until the patient mostly recover his whole heart after 3 months, because there will be a period, or we can call it a hibernation period, which is the myocardial cell will sleep after such coronary event, acute coronary event. Okay. And finally, give us idea about when to go to work again, when to drive, and about his medication, about the risk factor control like diabetes, like cholesterol. Like
yes, of course. This is what we should warn not just the patients, those who are well and good, to avoid having a cardiac attack. Right. Dr. Mohammed, thank you very much for taking us to a tour in your hospital and showing us how the catheter really can save lives. Brothers and sisters, we've enjoyed having you with us. Hope you would have enjoyed the episode. Until next episode, inshallah. Assalamu alaikum wa rahmatullahi wa barakatuh.